Hi, this is Elliot Fishman, and welcome to our latest vodcast. This is going to be on gastric causes of acute abdominal pain with CT, but they're all going to be non-malignant causes. And what I'll do is we'll show you some cases, we'll let you think about the answer, and then we'll discuss it in detail. A lot of this material was from an exhibit we had several years ago, and hopefully you will enjoy it. So what we're going to try to do is look at some of the common and uncommon causes of abdominal pain due to gastric pathology. We're going to suggest clinical management pathways, and we're going to look at some of the key CT findings, also some of the pitfalls that can occur in these cases. Now, if you think about gastric pathology, you could probably categorize it into two different types, intrinsic and extrinsic. Intrinsic arising from the gastric wall or due to peristalsis. You're thinking about gastritis, ulcers, and again, we're thinking about benign, not malignant ulcers, though of course on CT you always can't be specific what indeed is malignant or benign. That's endoscopy. We'll talk about volvulus, gastric pneumatosis, and intussusception. And then we can talk about extrinsic causes external to the gastric wall, like trauma, fistulae, chemical gastritis, hemorrhage, and foreign body. Now, CT is the study of choice. One of the key things with CT, and we tell you this all the time when we talk about protocols, you need good gastric distension. Positive contrast or neutral agents like water. We tend to use water more and more now. All patients can really tolerate drinking 500 to 1,000 cc's of water, have the water cold, have it taste good. It's easy to do, and you need to do it just like 15 minutes before the patient gets scanned, and then maybe another cup when the patient gets on the table. If you have underdistension, you can overcall or undercall pathology. If the patients aren't cooperative, there's motion artifact. You can have problems, though this is less of an issue. And of course, history is great to have, but often when you do, particularly in the ER setting, the history is going to be very minimal and may not have the information you really need. Dedicated protocols, as we said, water is an ideal agent. If you ask me when I will not use water, if I'm looking for a fistula, and I'll show you one example, let's say a fistula between stomach and bowel, then you want to use positive contrast because it makes it easier to see a fistula. We also will be using routinely IV contrast. Depending on the scenario and what we're thinking about, it could be dual phase imaging. Surely if you're thinking about a GI bleed, dual phase arterial and venous are ideal. But if you're just doing routine imaging of the abdomen or the stomach perhaps, you might be doing just venous phase imaging at about 70 seconds. Let's look at this case. 75-year-old woman, nausea and vomiting. You see diffuse thickening of the gastric folds, literally from the body through the antrum of the stomach. What are we dealing with? Not the most difficult of cases, wall thickening lobulation. If you ask the question, can I exclude totally cancer? The answer is no. But this was infectious gastritis. Typically wall thickening, adjacent fat stranding. We talk about this halo, but again, I don't think it's as helpful as the few articles that have mentioned it. In a case like this, I'll be describing diffuse gastric wall thickening. Depending on the age of the patient and clinical history, I'll say gastritis, but I will say I cannot exclude underlying malignancy. Endoscopy then will be done invariably to get biopsies. In terms of wall thickening, typically gastric cancer is a centimeter or greater, but so can gastritis. And particularly if you're doing really good CT, you can pick up neoplasms that are under a centimeter in size. In terms of enhancement, certain gastric tumors, carcinoid tumors, glomus tumors enhance. Typically, adenocarcinoma is relatively hypovascular. In terms of clinical management, in this case, endoscopy is really the way to go to exclude neoplasm and try to be more specific as to the cause of gastritis. You'll be making sure the patient doesn't have underlying H. pylori infection. And in this case, it was simply infectious gastritis. Here's a second case. When you look at this case, there's food layering out with fluid in the stomach, and then there's a area of focal thickening as we get closer to the antrum. What's going on here? Here's the sagittal view. To me, this looks like a mass, and I surely would worry about the possibility of a focal carcinoma. At endoscopy, this was a gastric ulcer, non-perforated. Obviously, on the CT, you cannot say that this is simply a benign ulcer, which this indeed was. CT findings of ulcers, typically focal wall thickening. You may see adjacent fat stranding. You may see a crater. I've shown you several cases previously of ulcerations shown very nicely with cinematic rendering when the stomach's well distended, looking directly at the ulcer. In these cases, endoscopy will be necessary to make certain the patient doesn't have a neoplasm. And again, these patients will be treated medically after endoscopy. Here's another case, acute abdominal pain. The thing that's most impressive here, first of all, is this pneumoperitoneum. So now we're thinking, in a patient without surgery, without trauma, pneumoperitoneum, there are many causes, but most commonly I'm thinking about a gastric ulcer, and I'm thinking about diverticulitis with perforation. Of course, this lecture is on the stomach, so it makes it easy. You can see the stomach wall is diffusely thickened, and there's an ulceration in the posterior wall. There's fluid around the stomach. There's perforation. Malignant, benign, I can't tell you, but I know there's an ulceration with perforation. In terms of non-perforated ulcer findings, things you can see are focal wall thickening, adjacent fat stranding, and an ulcer. Once you see perforation, like in this case, the extent goes far beyond the stomach. Again, you cannot exclude in a case like this that this was a malignant ulcer. Complications from ulcers and perforation, obviously, fistulous tracts, pneumoperitoneum, as we saw in this case. And again, endoscopy is the next step in the management of this patient. Because of the patient's perforation and pneumoperitoneum, this patient will go to surgery. Again, a very nice example of a perforating gastric ulcer. Another case. In this case, in this patient with acute nausea, we kind of look and say, where is the stomach? The stomach seems to be above the diaphragm. You can see the aorta, you can see the esophagus, but where's the stomach? And then you could see, where is it on that coronal perspective as well? What is exactly going on here? The stomach is in the wrong place. Look at the relationship to esophagus and to duodenum. And in this example, what do you need to be thinking about? Some sort of twist or volvulus. And this is the classic organoaxial. Two types of volvulus. I'll show you another example. Organoaxial. Again, a very, very nice example. You can see the fluoroscopy image in this patient. Sometimes it's hard to talk about gastric volvulus because sometimes it looks like just a large hiatal hernia and you tend to blow it off as a hiatal hernia, but you need to be very careful. It's a rotation around the gastric long axis. There's a presentation, epigastric pain, intractable retching, inability to pass an NG tube into the stomach. That may be one of the best clinical signs, and this is all part of Borchards's triad. Organoaxial makes up 2/3 of gastric volvulus. There's typically on CT reversal of the greater and lesser curvatures. There's association with a paraesophageal hernia, and there can be evidence of ischemia, particularly if the diagnosis is late. You may see air in the esophageal wall or in the gastric wall. Again, these patients will go to surgery. It's an urgent, do not pass go, go directly to surgery. Another case, speaking about volvulus, here we're looking, you can see where I marked the esophagus, but the stomach seems to be both above and below the diaphragm, and it kind of looks almost like a dumbbell configuration. The coronal view is very good because you really have what looks like a twist. The whole orientation of stomach to esophagus and to duodenum is really incorrect. And that's what gives you the information. I think it's very important. In this case, a good example. When you're looking at things at the chest and abdomen, when you're looking at things at the level of the diaphragm, it's very good and it's critical to be looking at both coronal and sagittal views. Sometimes from the axial, it's just really hard to put things in perspective, but when you have the coronal view, it makes life a whole lot easier for you. And in this case, it was a mesentero-axial intussusception, rotation around the short axis of the stomach. It's much less common than the organoaxial volvulus. Typical findings: antrum superior to GE junction. Rotation may be less than 180 degrees. There's no association with a diaphragmatic defect. And again, ischemia can occur, but it's often late in the process. And again, this is one of those surgical emergencies. This is why it's so important to be able to recognize this, because this patient is not going to be followed, repeat the scan tomorrow. This patient, whether it's 3 in the morning or 3 in the afternoon, will be going to surgery directly. Another case. What do you see here? Well, at first glance, you see fluid layering out of the stomach, but then you look at the posterior aspect of the stomach and you say, what exactly is going on over here? Now, we always think about air in the small bowel wall, air in the colon wall. We don't think about esophagus and surely stomach all that often, but this is a nice case of gastric pneumatosis. Now, you can see gastric pneumatosis for a number of reasons. It can be infection, it can be ischemia, it can be iatrogenic, post-NG2 placement perhaps, post-biopsy perhaps. It could be due to caustic injury, someone taking some toxic material like Lysol, for example. On CT, again, the key findings, and we speak about this looking at small and large bowel as well, non-dependent gas in the bowel wall, adjacent fat stranding, and perhaps evidence of ischemia. In terms of clinical management, trying to figure out the etiology, often endoscopy will be done to make certain the patient doesn't have ischemia, and depending on the clinical scenario, anywhere from antibiotic therapy to surgery will need to be done. Another patient. You look at the stomach, it's well distended, particularly on the coronal views, and then you say, what's going on in the antrum? What exactly is going on here? It kind of looks like a mass, but it kind of looks like a twist. That's a clip from prior cholecystectomy. What's going on here? Well, what this is an intussusception. We think about small bowel intussusceptions, anywhere ranging from the intermittent incidental jejunal intussusception to metastasis to tumors in the small bowel. We talk about tumors in the large bowel like cecal tumors intussuscepting or intussusception at the ileocecal valve. But gastric fistulae can occur as well, but they're typically rare. We've seen it with hypertrophic polyps, as in this case, but we also can see it with things like lipomas. The typical CT findings: gastric outlet obstruction, visualization of the intussusception, and again, you can often be able to be specific as to its cause. In terms of clinical management, you can try to do reduction, I guess, but at the end of the day, the patient will need to go to surgery. In this case, it was a large hyperplastic polyp, which was resected. Again, a very, very nice example. What about this case? This patient had trauma. Now, I will admit gastric trauma is rare. I mean, you can have a gunshot wound, you can have a stab wound, but in terms of like an MVA, we think about the spleen, we think about the liver, the adrenals, the pancreas, the small bowel, the mesentery, the ribs, the lung, you name it. But here, what's going on in the stomach? Now, of course, one thing is, could this simply be lack of good distension? But if you assume the stomach was distended, this was a mural hematoma. Now, I have to admit, I've seen very few cases of gastric wall hematomas from trauma. Again, the stab wound, the gunshot wound, and then you see multiple other injuries. To see this isolated injury will indeed be very interesting. These patients can be treated conservatively, and this patient did well. What findings do you look at? Well, gastric trauma, fat stranding, focal wall thickening, as in this case, gastric rupture, which is exceedingly uncommon, and hematoma, which is rare. Again, typically patients will have other sources of injury as well. I mentioned the spleen, the liver. I guess you can get a gastric wall hematoma also in a patient who's had a G-tube placed, and occasionally one of the complications is hematoma in the wall of the stomach. We also talk about complications, pneumoperitoneum, hematoma in the abdominal wall are all possibilities. In terms of penetrating injuries, pneumoperitoneum, hemorrhage, regional organ injury are all things we think about. And in terms of management, it really depends on how the patient's doing and what you find. Surgical consultation is ideal. Patients may need interventional radiology for embolization if you indeed see active hemorrhage. Most patients will be observed and monitored carefully, and they indeed will do well. What about this case? This patient had halitosis, really bad halitosis. And what you can see here, there's positive contrast, and there's a tract between the stomach and the region of the patient's splenic flexure. That's a fistula between stomach and colon. Now, the thing about this case, I mentioned before, if I'm thinking about a fistula, I'm definitely going to give positive oral contrast, and you can see why it works so nicely because you can see it. Now, you can have perforations for a number of different reasons. You can have tumor growing from stomach to colon. Just tumor is a good example. You can have a perforating ulcer that extends to the colon, very rare. You can have a colon cancer which grows upward into the stomach, pretty uncommon as well. Clinical symptoms, abdominal pain, fecal and vomiting, halitosis, undigested food in the stool. Again, causes. Penetrating benign gastric ulcers are most common. Neoplastic, I mentioned, gastric tumors or colon tumors, and of course inflammatory processes ranging from toxic chemicals to Crohn's disease. CT findings, local inflammation. You can see the fistula, again, positive contrast works nicely, and of course the early contrast going into the patient's colon. Surgical management will depend on the cause, but typically these patients will go to surgery. It's rare to manage these patients conservatively because you're not going to be able to solve anything. Here's another case. Patient with nausea following initiation of prednisone for sciatica. Again, patients on steroids, ulcerations are common. Look at the gastric antrum. I would consider carcinoma as well, but ulcer disease is a good thought. And this was chemical gastritis. Can be due to NSAID use, corticosteroids, or antibiotics, typically focal bowel wall thickening, adjacent fat stranding, and you may or may not directly visualize the ulcer, which we see very nicely in this case. Again, you cannot exclude carcinoma. If I look directly at this case, how do I know this is not a carcinoma? The lower density in the submucosal region is more common in inflammation than cancer, but it can be seen there as well. This is a typical case where the patient will go for endoscopy particularly to exclude neoplasm. So they'll be getting biopsies to make sure we're not missing a cancer. And again, management clinically will be, in this case, stop the patient's steroids. Other cases, patients will be put on different types of medication to resolve the patient's ulcerations and gastritis. Another case, patient with cirrhosis, dizziness, and anemia. What you see in the stomach is high-density fluid. When you see high-density fluid in the stomach, it means there's hemorrhage. Yes, you can ingest some matter, but then that's super high density. Things like antacids, for example, or just food can be problems. One of the things we talk about is lower GI bleed all the time, but we've given you lectures on upper GI bleeding. A really, really nice example. What are the causes of upper GI bleeding? Ulcerations, varices, Mallory-Weiss, vascular tumors. Things we'll see, contrast extravasation. Again, the importance of dual phase imaging when you're looking for bleeding. You'll look for intraluminal hematoma, which is in this case here. If you don't see active bleeding, you see hemorrhage, but you don't see bleeding. It may simply mean that the patient bleeding is not going on at the time of the study, not uncommon. In this case, you can see the cirrhosis and varices. And again, clinical management, typically endoscopy, occasionally interventional radiology with embolization. And depending on the scenario, surgery may be indicated, particularly if it looks like the cause of hemorrhage is going to be a GI malignancy. Here are two separate patients with a history of anxiety disorders, and what you can see in both of these cases is there's something in the stomach. In the upper image, you can see a toothbrush. In the bottom image, a Christmas light. Foreign bodies are not that uncommon. We talk about them in kids, where kids swallow anything, particularly coins. But there's some patients, particularly with mental instability, that will swallow things. I saw a case recently of a battery. Most of the time, the patients will have the foreign body pass. Other cases, you'll have to do endoscopy and remove it. Occasionally, you can have perforation from the stomach, though more commonly perforation is distally, particularly near the ileocecal valve region. So CT, we see the foreign body, we can make the diagnosis. Sometimes clinically, you think the patient may have swallowed a foreign body, but you're not sure. CT is very good at that. We look for signs of inflammation. We look for signs of perforation. And again, endoscopy can be done, but if you have a lot of foreign bodies or it's something which is very sharp and can't be removed, then surgery will indeed be necessary. So I've gone through a number of cases. Several things to remind you: dedicated gastric protocols can improve sensitivity and specificity. Negative oral contrast water is ideal. It's easy to miss gastric pathology if you're not careful, if you don't have good protocols, and if you're not looking carefully at the stomach. You also can overcall. I know I see a lot of time people will say gastric wall thickening, but it's simply lack of gastric distension. Again, the difficulty we have at times of distinguishing tumor from benign ulcer. Again, it can be somewhat tricky. Endoscopy may be necessary. And again, there are a number of things where there's surgical emergencies: volvulus, gastric pneumatosis, foreign body, and perforated gastric ulcer. So with that, we've gone through a bunch of cases. I hope you find them helpful. And all I can say now is thank you for paying attention, and see you next time. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.